So guys, just let me know when you can see the screen. So I'm just going to start the screen share. Please type yes in the chat box if you can see the screen. So just begin. I'm going full screen now. Hope you can see my screen now. So today we are going to discuss about a very important topic, which is MSK ultrasound for the knee joint, and I'll just introduce the faculties and speakers in a moment. Before we begin, as is customary, I'll just like to take you through this short introduction. Pain medicine world over has got a lot of diverse issue and variable standards. Wherever I go, I see different issues and variable standards, different learning requirements, as well as different offerings still. And money and time are constraints for the pain physicians to practice. And Mumbai Pain School is an initiative of Panesia's Fine Wellness and Pain Relief Center, which is going to just bridge this gap. We have focused on online education, and most of our content is free. And as a result, we have been able to propagate the education to a great extent. So we focus on online learning and on-demand videos, content, both free and paid. Most of our content is free, but we also conduct hands-on workshops, and we're very fortunate to have expert faculties from all over the world. It is said that the best teachers, they teach from the heart and not from the book. So what's a journal club? It's just a club with the difference that we're going to evaluate critically the recent academic literature, which is based on a defined subject. And of course, the attendee participation is extremely important. And so I encourage all of you to just type in your questions, comments, suggestions, everything is welcome. It's tough to be regular. So every time I see around 20-30 people on Zoom and maybe some 400-500 people on various social media who see these videos. And the good or the sad part is that every time people change. So try to be regular for maximum learning. Journal clubs are very important. Even Harrison used to hold his own journal club for critical evaluation of the academic literature twice a month. So I request both the speakers to stick to the time. Discipline is very important. Healthy skepticism or praise is welcome. So I request all of you, including the moderators, faculties, to kindly chip in with your take on the papers. This is about me. I'm practicing in Mumbai, and today we have with us Dr. Kanchan Sharma. She's done her MD, Focus MSK, RMSK, which are world-class certifications. She's a Focus education provider of Post Focus Certification Academy, USA. She's a faculty of the Orthopedic Academy in UK, recipient of multiple awards, co-author of multiple books, chapters, and of course, inventor and an avid publisher as well. So I think she's already there. Just let us welcome her. Welcome, Dr. Kanchan. I've just made you the co-host. You can unmute yourself. You're not audible. Just wait.
I think now you will be able to hear me. So thank you so much. And I hope everybody is going to have a great learning session. And this, especially the two things which we are going to discuss, has got lots of loopholes. So we'll be pointing out today. And I hope everybody is going to go back home with lots and lots of knowledge. So I welcome all of you on behalf of Mumbai Pain School. And thank you so much for.
You're always welcome. Okay, so our second faculty is Dr. Aanchal Sharma. Of course, she's been a regular faculty with us, so most of you know her already. She's done her MD anesthesia from PGI Chandigarh. After that, she's done her fellowship in pain medicine from Chicago, United States. And she's also board certified from the American Board of Pain Medicine. She's currently the head of department pain and palliative care at BLK Max Hospital in New Delhi. Dr. Aanchal, are you there? Yes, you are there.
Yes.
Welcome, Dr. Aanchal.
Yeah. Thank you. Thank you so much.
Great. So I think let's go on. So I'll just stop my sharing. So I request Dr. Sasmit, I think is going to present first. So Sasmit,
Yes.
please put on your slides. I will just introduce Dr. Sasmit. Yeah, can you put your CV slide?
Can you see the screen, sir?
Yeah, I can see the screen. Just put the next slide and I'll introduce you. Okay, so Dr. Sasmit Deepak Lotliker is MD, Fellowship in Pain Medicine from DYPU University, and he's consultant interventional spine and pain physician at Manipal Hospital, Goa, Boca Multi-Specialty Hospital, Goa, Mani's Hospital also in Goa, and he's the director of Thawasmi Spine and Pain Clinic at Goa. So over to you, Dr. Sasmit.
Thank you, sir, for the introduction. Good evening, everyone. Today I'm going to present this paper, the ultrasound-guided anteromedial joint line approach, a targeted corticosteroid injection technique for patients with medial knee pain. So this was a retrospective study published in the Pain Physician Journal in 2022 by Ya Ting Chen, MD, Philip H. Yun et al. In the Department of PMR, Medicine and Rheumatology in the Massachusetts General Hospital, Harvard Medical School, Boston. Coming to the introduction, so as we see, osteoarthritis along with the medial collateral ligament injury, medial meniscus injury and inflammatory arthropathy are some of the most common causes of medial knee pain. Medial knee pain is more of a clinical diagnosis which is supported by X-ray, focus and MRI. The use of ultrasound will improve the clinical outcomes by reducing the procedural pain, increasing detection of joint fluid and increasing the accuracy of intra-articular injection. Ultrasound-guided anteromedial joint line approach has an entry to the medial knee and is more effective when the pain generators are in the medial compartment, such as in synovitis. And there are no dedicated studies for this approach so far. Coming to the aims and objective of this study, it is to assess the clinical characteristics, ultrasound findings, and clinical outcomes for patients with medial knee pain who have received ultrasound-guided corticosteroid injection via the anteromedial joint line approach. Coming to the study design, this was a retrospective review of medical records. Ethical committee approval was taken from the Institutional Review Board, and it was presented to an academic rheumatology musculoskeletal ultrasound clinic at an urban tertiary care center. The duration of the study was from January 2016 to April 2020. Coming to the inclusion criteria, any person who was aged more than 18 years and older, presence of medial knee pain, and those who have received at least one ultrasound-guided AMGL knee corticosteroid injection in either one or both the knees. Exclusion criteria were those people who were hospitalized for a major health event which was unrelated to the knee pain within 6 months after the injection, such as stroke, heart failure, or asthma exacerbation. Coming to the assessment of pain relief, it was all the clinical outcomes, at all the clinical encounters, electronic chart review was conducted. The patients were then categorized into two categories, responders and non-responders. So responders had good pain relief, reduced analgesic usage and increased physical activities, whereas non-responders were those people who were not meeting any of the responder endpoints. Coming to the technique of ultrasound injection, patient position. So patient was in sitting position on the exam table with the knee in 20 to 30 degrees flexion. The ultrasound probe was placed on the anteromedial knee. As we can see in this figure, the ultrasound probe is placed in the longitudinal axis in the anteromedial part of the knee. And we visualize the junction of the medial femoral condyle, the medial meniscus, and the medial tibial condyle. So the technique, sterile preparation was done, anesthesia for the skin was given, and using a 25 gauge 1.5 inch needle, it was advanced through an out of plane approach into the synovium at the distal end of the medial femoral condyle without injuring the meniscus. The drug which they injected was 1 ml of methylprednisolone 40 mg and 2 ml of 0.5% bupivacaine. Confirmation of the drug spread was done on ultrasound. So as we see here in the first figure, this is the pre-injection ultrasound image of the longitudinal axis. These arrows which are here, which is showing the chondrocalcinosis. If you see this dotted line over here, this is the synovial thickening. And this asterisk sign which is seen over here suggests the medial meniscus protrusion. Now in this second image, we can see the needle tip position in the cross section. This needle tip is in the out of plane approach. Coming to this image in the ultrasound, this is the post-injection ultrasound image. This is showing the hyperechoic injectate which is spreading along the medial compartment of the synovial cavity. And this image is basically a schematic diagram which shows the out of plane approach. So this is the transducer and this is the needle in the out of plane approach. So we have to visualize the needle tip. Coming to the statistical analysis, so descriptive statistics was done for demographic and clinical variables. For the responder and non-responder group, for continuous variables, a two-sided student t-test was done. And for the categorical variables, two-sided Fisher's exact test was done. All the analysis was then performed using the RStudio IDE software, and a p-value of less than 0.05 was considered to be statistically significant. Coming to the results and discussion, so the research patient data repository was identified 733 patients, of which only 75 patients met all the inclusion criteria. So coming to the demographics, most of the patients in the study belong to white as well as women category. The non-responders on an average were older and had a lower BMI as compared to the responder group. Also, the non-responders had a higher mean Charson comorbidity index score, which is the score for suggesting the comorbidities. So if we see here in the demographic comparison, the age group of the non-responders is around 74.4, whereas the age group of the responders is around 64.4. Also, the BMI of the non-responders was less than that of the responder group, and the Charson comorbidity index was much higher in the non-responder group as compared to the responder group, which are all statistically significant. Coming to the duration as well as the knee pain location as well as use of the concurrent pain medications, all of them were comparable between the two groups. Coming to clinical diagnosis and the imaging findings, in the final primary diagnosis, around 60 patients had osteoarthritis, 5 patients had medial meniscus injuries, 3 patients each had gout, pseudo-gout, and medial collateral ligament injury. Among the different pathologies which were identified on the ultrasound, the most common one was synovial thickening or effusion, which accounted to 62.3% of the total pathologies. The others were meniscal abnormalities, medial collateral ligament thickening or sprain, and osteophytes and chondrocalcinosis. So here we see in this table, we see the primary knee pathologies and the secondary knee pathologies. As we have discussed, the osteoarthritis of the knee was the most common, followed by meniscus injury, gout, pseudo-gout, and MCL strain. These are all the abnormal pathological findings which were seen on ultrasound examination. So as we see here, synovial thickening or effusion was the most common finding, followed by meniscal abnormality, MCL thickening, and osteophytes. Coming to prior treatment and clinical outcomes, 98% of the patient had immediate pain relief post the ultrasound-guided anteromedial joint line injection. At the 11 weeks follow-up, around 60 responders and 6 non-responders were found. The patient response was determined using subjective history, subjective reports of the pain improvement, decreased usage of analgesics, and increased physical activity. Only one patient had steroid flare within 1 week of injection, which had self-resolved. At the 6-month follow-up, around 22.4% patients received a repeat ultrasound-guided AMGL injection, which had similar relief. Only 21% of the patients surprisingly continued with physical therapy after the ultrasound-guided AMGL injection. So this table shows the relief pattern. So as we see here, around 98.7% patients had responded among the non-responders, whereas 100% of the among the responders, whereas the non-responders, 100% patient had responded in immediate post-op this thing, whereas the numbers dropped down at 11 weeks follow-up period. Coming to the discussion, this is the first study to examine the clinical characteristics, the focus pathologies, clinical outcomes, and the use of diagnostic and therapeutic services among patients who received the ultrasound-guided anteromedial joint line injections. This study suggests that focus is a very useful tool in identifying medial compartment knee pathologies. The most common focus pathology which was identified was synovial thickening, followed by medial meniscus abnormality, MCL strain or thickening, and osteophytes. The diagnostic value of focus was important in evaluating ligaments, synovium, meniscus, bony irregularities, and crystal deposition, suggesting lower utilization of MRI and radiographs in these conditions. Focus also expedites the clinical decision-making process for managing medial knee pain. The suprapatellar approach, which is commonly used, is technically more challenging, especially in obese patients. And overall, the ultrasound-guided anteromedial joint line injections were well tolerated. They brought short-term to medium-term pain relief in patients with failed suprapatellar injections. However, the long-term benefit of this injection was yet to be established, and advanced knee osteoarthritis patients were less responsive to the corticosteroid injections. To conclude, the use of focus will help to expedite the clinical diagnosis of medial knee pain. It also helps target the most symptomatic compartment with ultrasound-guided corticosteroid injections. The ultrasound-guided AMGL corticosteroid injection is safe and feasible procedure, provides effective short-term to medium-term relief for those with medial knee pain, and it is useful in obese patients and prior failed superolateral and or suprapatellar knee injections. The limitations which they have accepted is that a small sample size was included, confounding factors were present, which included use of analgesics and physical therapy, and the study's generalizability was very limited because a very high percentage of patients who were included were women and cancer patients, as the clinic was a referral center for palliative musculoskeletal pain management for patients with cancer. Coming to the critical analysis of the article, so a randomized controlled trial would be required to assess the long-term clinical impact. Also, a larger sample size would be required. The study involves more of cancer patients and women only. So a broader category of patients is required so that we can study a broader category of patients. Also, in this study, they have used the out-of-plane technique. So needle tip visualization usually becomes difficult in out-of-plane technique, and we can also injure important structures like the medial meniscus, which is very close when we are doing the using this technique. Also, in conditions like chondrocalcinosis, gout, and pseudo gout, calcifications may be present, and this will help. This will make it more difficult to differentiate from the needle tip. Secondly, when we are in the era of regenerative therapy, there is no mention or comparison with any regenerative options like platelet-rich plasma therapy. Also, it is a known fact that steroids can accelerate the degeneration and progression in cases of osteoarthritis. So, no long-term analysis of the outcomes was done of the steroids. Also, autologous condition steroid serum could have been a better option in case of infection and inflammation, but no comparison or mention about this also has been made. Lastly, there is no comparison made with the medial and lateral pre and parapatellar recess approach, and also with the infrapatellar approach. So the take-home message is ultrasound-guided anteromedial joint line approach for corticosteroid injection is a safe and feasible procedure. It provides short-term to medium-term pain relief, and it is useful in obese patients. It is effective in patients with prior failed superolateral or suprapatellar injections. Thank you.
Thank you, Dr. Sasmit. I think we'll take both the questions together. Will that be fine, Dr. Kanchan, Dr. Aanchal?
Yes. Yeah. Let's take it ahead.
Yeah, okay. Okay, so let me introduce the second speaker. Dr. Akhil, can you put your CV slide? Yeah. Dr. Akhil Bhalla is MD, FIPM, FIAPM. He's assistant professor in charge of pain medicine unit at the Department of Anesthesia and Pain Medicine at Adesh Medical College in Ambala. And he's a founder and consultant for Pinnacle Advanced Pain Management in Chandigarh. So he's also the pain consultant at multiple hospitals in Chandigarh. So over to you, Dr. Akhil.
Thank you for the introduction, sir. Very good evening to everybody. So the second article which we'll be discussing for this journal club is a case report. So it is titled as a case for chronic deep infrapatellar bursitis, which was complicated by patellar tendinopathy and its evaluation with musculoskeletal ultrasound. So this was a case report which was published in Curious in 2022. This was published by Debashish Jena et al. And the study was conducted in the PMR department of All India Institute of Medical Sciences, Bhubaneswar in India, and also the anesthesiology department of Sri Ramachandra Medical College in Cuttack, India. Okay, coming to the introduction. So bursitis, as we all know, is inflammation of bursa, which is a synovium-filled, fluid-filled sac-like structure, typically around the large joints such as a hip, knee, shoulder, or an elbow. What is the role of a bursa? It reduces the friction between the adjacent structures which are moving. Most common causes of bursitis would be overuse, direct trauma, repetitive microtrauma, any crystal disease, hemorrhage, infection, or even a systemic inflammation. So deep infrapatellar bursitis, the location is the posterior aspect of the distal patellar tendon and the anterior aspect of the tibia tuberosity. So the location of the deep infrapatellar bursa is relatively deeper, so it becomes difficult to examine only on a clinical examination. The role of MRI has already been established, it is gold standard, but the role of ultrasound is still not very clear in the diagnosis. Coming to the case presentation. So the history was presented as a 32-year-old woman with a history of fall from bike 1 year prior and presented with a chronic anterior knee pain on the left side. So the authors gave left side, so it was basically the left leg on the lateral aspect. So the pain was intermittent, dull aching, mild to moderate in severity and present for the past 10 months. The pain was on the VAS score, it was 5 out of 10. The patient was a housewife and she provided no history of any chronic illness, frequent kneeling, or even jumping activities. The patient had already consulted physicians for intermittent pain exacerbations and was being diagnosed as only pain, and painkillers were being given without a proper diagnosis. She had gradually developed persistent discomfort over the anterior knee, and the pain now was aggravated by kneeling, heavy activities, and extreme flexion and extension of the knee. So this was the image that was provided by the author. On the lateral aspect of the left knee, you can see some erythema and mild swelling over the inferolateral aspect of the patella. And there was a healed scar on the lower aspect of the patella, which was just adjacent to the painful area. According to authors, this was the painful area. On palpation, it was slightly warm, and point tenderness just lateral to the distal patellar tendon was seen. Additionally, there was mild tenderness also on the distal 1/3 of the patellar tendon, that is at the superior aspect of the tibial tuberosity. The knee range of movement was painful at the extremes of flexion and extension of the knee. So routine blood investigations were normal. Radiograph AP lateral of the knee joint were normal. There were no any abnormalities. On the ultrasound examination, the authors gave 4 such photos, and the images which they provide was longitudinal and the transverse scan, and comparing the normal knee to the affected knee. So this was the longitudinal scan where you can see the tibia. This is the patella. This is the Hoffa's fat pad. This is the patellar tendon, and the authors have even tried to show that they have measured the tendon in this aspect, whereas no measurements were given in the paper. And the normal knee, this is the bursa. This black lining is the bursa, and the normal knee, apparently there was no bursitis. On the affected knee, on the longitudinal scan, you can see light, the B part which has been written as a black line is the bursitis, and the patellar tendon seems inflamed as compared to the normal knee. On the transverse section also, you can see the patellar tendon echogenic on the normal side and heterogeneous patellar tendon on the affected side. The bursa is seen distended, whereas it was not distended in the normal side, and it was distended and thickened patellar tendon was seen. So the diagnosis of deep infrapatellar bursitis was made, and it was associated with patellar tendinopathy. This was done by the use of the ultrasound, and when the bursa which was distended was compressed under the probe, it showed a positive probe tenderness. Also, the patellar tendon was thickened, and it showed a heterogeneous echotexture. The author said that on color Doppler, they did not show any increase in vascularity. Okay, so now coming to the intervention which the authors did. So this was the image provided by the authors. This is the tibial shin and the patellar insertion of the patellar tendon. This is the longitudinal view, and the N which has been kept by the authors as shown as the needle insertion. So apparently this is a longitudinal view with the needle coming in the in-plane approach through the patellar tendon into the bursa. And they have said that they gave an injection of 20 mg of triamcinolone plus 2 ml of lignocaine hydrochloride, total of 2.5 ml, instilled in the bursa in an in-plane. But here they wrote is at a lateral approach, but on the image it was given in longitudinal view, and no post-procedural complications were encountered. Post-procedure, the patient was advised ice application thrice daily for 15 minutes, each for a period of 1 week. After a week of injection, stretching exercises of the quadriceps were started, followed by eccentric strengthening, and 2 times a day, which consisted of 3 sets of 15 repetitions each. Follow-up after 3 months with complete resolution of symptoms was observed. occasional activity-related discomfort in the anterior knee was attributable to the tendinopathy. She was advised to continue those strengthening exercises and activity modification. Now coming to the discussion. So deep infrapatellar bursitis is relatively uncommon as compared to the other bursal inflammation seen. It is usually difficult to detect because it is deeper to the patellar tendon inferiorly. Swelling may be seen adjacent to the distal patellar tendon and point tenderness can be elicited. It is frequently seen in runners and jumpers, which can often be confused with jumper's knee, and jumper's knee may present with the symptoms that the authors have explained, and due to overuse of the extensor mechanism of the knee joint. Other conditions with a similar presentation would be infection, Osgood-Schlatter disease, gout, spondyloarthropathies, and even juvenile idiopathic arthritis. So the routine investigations for this would be to rule out any infection or systemic inflammation. Aspiration may be done to rule out infection or bursitis, which could be secondary to a crystalline disease. A plain radiograph can be taken in suspected cases of traumatic etiology to rule out any fractures, maybe Osgood-Schlatter disease if associated with any calcification in the bursa. So of course, the imaging modality of choice would be an MRI. And on a musculoskeletal ultrasound, the patient would lie spine with 30 degrees of flexion, slight flexion to straighten the tendon. Now, a point to be noted is that you should not apply any extra pressure with the transducer on the area of the scanning, as any small the bursa is relatively small and it could flatten, leading to non-visualization of the bursa. The examination should be done preferably in two perpendicular planes, that is longitudinal as well as transverse view, and measurements of the bursa should be taken in both the planes. The infrapatellar bursa is appreciated in a healthy knee as a 2 to 3 mm flattened and an anechoic fluid-filled structure. In patellotendinopathy, what you will see on a musculoskeletal ultrasound, that you will see a loss of anisotropy of the tendon and an increase in the tendon thickness with a heterogeneous echo texture, as was shown in this paper as well. Color Doppler may show increased flow, indicating an ongoing inflammation. On a real-time scan, the pain may be reproduced during transducer palpation. And most importantly, always go for an examination of the asymptomatic side to compare the results before reaching any conclusion. So what would you do if you encounter a patient of deep infrapatellar bursitis? The initial management would be rest, ice application, and anti-inflammatory medication. Activity modification must include avoidance of certain specific activities such as jumping, running, and kneeling of the knee joint. Aspiration may be done to rule out suspected cases of crystalline deposition disease, and especially if the knee has a significant distension, and microscopy or culture may be sent. In a recurrent or resistant case of inflamed infrapatellar bursa, you can do an appropriate steroid injection as it was done here. When done with an ultrasound, it improves the accuracy of the procedure and thereby preventing an intratendinous injection. It's ironical that the authors wrote this because they went through the tendon to do the procedure. Rehabilitation program should be done with stretching and eccentric strengthening exercises along with activity modification. So the limitations which the authors accepted, it was that they accepted an inherent limitations of the case report. It was limited by the absence of an MRI of the patient. However, the ultrasound confirmed the diagnosis and clearly delineated the inflamed bursa as well as the thickening of the patellar tendon. They also suggested that the causal association between a chronic deep infrapatellar bursitis and tendinopathy cannot be established with just a single case report. So coming to the critical analysis of this paper. A gold standard investigation, that is an MRI, should always be done to rule out provisional diagnosis to come out to a definitive diagnosis. The choice of the drug which was introduced in the bursa, it has been seen that long-term damage can occur with both lignocaine and transendone, as has been seen in multiple previous studies. So I think the choice of the drug which was introduced in the bursa could have been different. Ultrasound guided intervention again was done in a longitudinal plane through the patellar tendon, which could have been avoided. So it is better always to do a lateral approach in the transverse axis where you can in-plane technique. So the take-home message could be that ultrasound is an excellent imaging modality to diagnose infrapatellar bursitis along with patellar tendinopathy. Both of these can be very easily diagnosed on an ultrasound. USG guided interventions are precise, easy, less time consuming, and very helpful in such cases, even for diagnosis and even for intervention. Thank you.
Thank you, Dr. Akhil. Now I'll just request both the faculties, Dr. Kanchan and Dr. Aanchal, to take over for any comments first, then probably questions which they want to ask the speakers or discuss with the audience. And I will also request the audiences to please type in your questions in the chat box, either on Zoom or those of you who are live on social media, guys, please type in and I will just pass it on to the faculties.
So coming to this paper which Sasmit has presented, I would just try to list out some of the things which are, very much updated before this paper have got published. So this was published in 2022. So first of all, when we talk about the injection technique which they have used is, they have made the patient, they have done this procedure in the sitting posture. I would always say that whenever you are doing a procedure, and that too with the knee, right? You do it in the supine posture. You keep any rolled thing below the knee so that you have a flexion of, approximately 20 to 30 degrees. That's what you expect. Fine. So that was the first thing which I could make out from this paper. Second was out of technique. Obviously, Sasmit has spoken about it, because when you go for an out of plane technique, and if you go like this, if you read this paper again, most of the procedures, they have been done by the residents. Okay. So if I will say that if I'm learning ultrasound for the first time, I will never be learning it with an out of plane technique. Okay. Because out of plane technique, it will only be a cross-sectional portion of the needle, which will be visible to you. If you go in plane, it is the tip and the shaft, which you will be able to see very nicely. So it's always advisable that when you are learning ultrasound, try to go for in plane technique rather than going for out of plane technique, and that too in your initial days. Fine. And of course, he has also insisted that when you are talking about gout or pseudo gout, right, you have the deposition of these crystals, you have the double contour sign, you have the deposition inside the cartilage. So what happens is when you are going out of plane technique, sometimes you might not be sure, okay, whether your needle tip has surpassed it, your needle tip has injured something, everything appears hyperechoic to you. So go for in plane. Third thing is, like, they have used methylprednisolone. Okay, so if you go by the literature, the systemic review, I think it has come in 2015. And so what they have done very good study about this toxicity on the chondrocytes. Okay, they have compared different steroids. So I'll be talking only about the methylprednisolone, though we have, lots of other steroids. They have really done good studies on the chondrocyte. So what is the recent recommendation is that they says that if you are using steroids, especially the methylprednisolone, the dose which you should be using is 0.01 mg per ml, or if you want to take it in the mg, it is only the 7 mg. So if you are using the steroid less than 7 mg, they have seen this, okay, and there are meta-analysis, there are systemic reviews, there are lots of studies people have done on it, that if you are using 7 mg, then it is very much beneficial for the chondrocytes, right? It increases the density of the chondrocytes and it also decreases the size of the lesion. But when you are going above 7 mg, right, it causes the degradation of the proteins. You have the reduction in the chondrocytes and you have all the catabolic things which are happening. So if you really want to go for steroid, it should not be more than 7 mg. And even like Drogo, who has done a very good study on the the human chondrocytes, he insisted that it's always better you go for only 5 mg if you really want to go for steroid. But if you see the recent era, when we are talking about so much about the regenerative therapies and all, using steroid in 2022, I will not be appreciating it, right? I think it is not the cup of tea for today's world. When we are talking about the regenerative therapies, we are talking about the ablative procedures, then using steroid again inside the joint, where we have the literature which says that how harmful it is for the chondrocytes. So we should not be going for that. And then fourth point which I could see is they have not checked if they have gone for this out of plane technique with the they have not checked where this injected is going. Usually, whenever you are injecting right inside the joint, you should see the suprapatellar recess. If you are not able to see what they have, said that they were not able to visualize the suprapatellar recess, so they have gone for out of plane technique. But how they have confirmed it? Just by seeing, okay, the patient has got a pain relief, we cannot confirm. When you are using ultrasound, you should always scan your suprapatellar recess. You should scan your, the parapatellar recess, that what you are injecting is actually spreading very nicely. So when you are using ultrasound, you make use of it, right? You do not just stop, you inject the drug and that's all, take out. No, you should always assess your recess, that there is a uniform spread of drug. And suprapatellar also, there are various techniques. If you're not able to reach it, right, you have, one is like you ask the patients to contract the quadriceps. Second thing is you follow the quadriceps tendon, you put it in the short axis, you try to look for this quadriceps tendon, you keep on following it down. You will see that at one point you will be seeing the suprapatellar fat pad which will be hanging down from the suprapatellar, from this quadriceps tendon. And obviously it is quadriceps tendon, you have your suprapatellar fat pad, then you have your recess, prefemoral fat pad, your articular is genuine, and then the bone, right? So at least if you know this, that okay, this hanging thing is suprapatellar fat pad, and then you just then you toggle your probe. So tendons will be exhibiting the maximum anisotropy, right? So the moment you will tilt your probe, you will really be able to understand that this is the tendon, this is the fat pad, and very hypoechoic line which you will be seeing, that will be your recess, right? And if you have an effusion, right, what they have said that if they have an effusion, so they will be giving the medial side joint injection also, they will be aspirating the effusion, and then they will be injecting inside the effusion also. So it means they are just reducing, they are increasing the dosage of steroid, right? So that also is not good according to this study. And when you have an effusion, your needle will, your effusion will be providing a contrast for your needle. So it is always, nicely, you can just put your needle if there is a little amount of effusion which is there. Then coming to the other aspects of this study is, they have written one line in this paper that this result suggests that the identified ultrasound pathology such as synovitis and osteophyte should be the therapeutic target for steroid injection. Answer is no. Why? Because synovitis you do not see only in inflammatory pathologies. You see it in infection also. So how will you be distinguishing between an infection and an inflammation just by and with an ultrasound probe? No, you have to take the history of that patient. If he is having, the systemic markers, they are increased, he is having fever, right? All those things we need to address. So I don't agree with the line which he has written. And osteophytes, yes, fine. They are the features of your degenerative arthropathy. Erosions are in favor of your inflammatory arthropathy. And they have talked so much about the synovitis, but they have not mentioned about the color Doppler activity. So whenever you will try to see the suprapatellar recess with ultrasound, two things you should do. Okay. So if it's a simple effusion, you just press it. Okay. If it gets displaced, everything is dispersed, right? And you put the color Doppler there. If it is not taking up, it is just a simple effusion. You need not worry. Secondly, if it is a synovitis, you're going to see the synovial proliferation. So the moment you are going to press it with the probe, it will not be compressible. You cannot displace the synovial things which have grown up. And if you put the color Doppler activity, yes, it will be taking up the color Doppler activity. But yes, again, you have the various things, maybe this time it has been there for a quite long time. Then obviously your color Doppler activity will come down. If he is on systemic drugs, then also you will not be able to see the Doppler activity in the synovial. So these are all secondary things, but three things you should always do whenever you are examining the suprapatellar recess for just an anechoic fluid. You just try to see whether it is just a simple effusion or am I seeing a synovial hypertrophy there, right? So this is the best way to look for it. And yes, I think that's what I have. I could see that, they have concluded with this article. And yes, you have another approach which Sasmit has already told you. Stanley Lamb has come up with a very good technique, though that is also a case series. But yes, we need to have lots of studies. But if you practice it, it will be very easy. Okay, that is an infrapatellar approach. We do have the parapatellar recess approaches also. If you are not able to see the fluid inside the suprapatellar, recess, you can always go for the parapatellar approaches, or you can go even for for the intrapatellar. I found I have started using intrapatellar. It is much more easier, to put the needle. So you also try, read that paper by the Stanley Lamb. I think this will surely be helping you. So anybody wants to ask anything, or Dr. Aanchal, do you want to add up something? You can, please.
Thank you. You have actually, very nicely delineated all the points. However, I just wanted to add, in addition to what, has already been said, that I was not fully convinced with the spread of the drug. It is whenever we inject the drug, we see kind of hypoechoic line, but it's like, I don't know if they purposefully injected air before just to delineate, or to get that picture. I don't know how they have clearly demarcated hyperechoic line, and they've mentioned it as a drug injectate, which was not convincing. And obviously, it's a retrospective study. So, we know that in a retrospective, whenever we choose to inject patients, it's always a selection bias in retrospective studies. Not all the patients are. And the category they have taken is very broad, like gout, pseudo-gout, even tumors. Tumors do not present, they just have medial pain. And even the patient who did not have relief from suprapatellar, they injected it. But I think the only thing we can take up from this paper is if patient, you have injected PRP or steroid by suprapatellar approach, or you have injected intra-articularly, but if still patient is complaining of medial knee pain, this is something we can think of. Injecting the medication medially, or in addition to, just dividing the dosage accordingly. If nobody is doing steroids, but even if you have to, this is the thing we can take from this paper. But the technique, the bias and everything, we have to, obviously.
I think he has missed sensory bursitis also. That is also one of the most important cause.
Yes.
He has not included that also. Like recently, I was seeing a case of ONE, and he was complaining of pain. The moment you scan, it's very easy. If it is bursitis, which is causing the pain, obviously you need to treat that. Otherwise, how the medial pain is going to go up, right? So I think he has not taken that also in account, and that is also should have been there, right?
I mean, he has taken medial meniscal injury.
Meniscus injuries and all.
One of those last ones you will even think of steroids. So
yeah.
Yes.
Great. So we have an audience question. Dr. Kritika is asking. This is quite a generic question, probably for somebody who is mostly starting their practice, probably. So many times we try to match the condition to the procedure and try to think that it is quite straightforward. So the question is steroid indicated for an MCL strain? So I think it's a very the question itself is very this thing, because now you need to differentiate between strain, sprain, and then what kind of injuries there, all the grades, everything. So it's definitely not indicated. I don't think it you need to pass it on also. So it's not indicated for MCL strain. So that's the answer. If you want to add anything to it, please feel free.
If she is suspecting, if anybody is suspecting of MCL strain, please send the patient for MRI. You can always have a correlation with your medial meniscus, and if you will miss it, it will be a great thing, because you have that buccal handle tear and all, everything is there. So if this is injured, at least have a look, because in ultrasound you cannot see, you can just see a portion of the meniscus. So if you really want to evaluate the meniscus fully, and if it is medial collateral ligament, right, not the lateral one, if it is MCL, then you need to send the patient, you need to get an MRI done. I think that should be done. That is the take-home message if you're expecting it's something related to sprain. And usually when you read the literature, when we say the sprains, usually if you go for the ligament injuries, they say let the body heal on its own.
Yes.
And when it is going to the stage where the body is not able to heal, that is the time you need to intervene. So just like related to your ankle sprain, the moment you see you're not supposed to inject, you give some time for your body to heal that on its own. If the body is not able to heal, you please intervene.
So probably these questions arise because there is no clear pathway and nobody teaches you how to go about it. So maybe I'll just in a line tell you how you can probably most of us have done it in this way, and now it is even more imperative because there is a knowledge explosion in this field, and there's a lot of literature coming up which was not very frequent earlier, because now more and more non-radiologists are coming in who are more and more clinically oriented. And the thing is that you need to focus on the diagnosis part, but rather than being needle jockeys, so try to focus on the diagnosis part also. So a good way to start is probably when you are new, if you can't do a course or do a fellowship and still you want to be doing something, so maybe you start with the scanning, and then taking the help of a colleague who is expert in diagnosis, and then discuss your cases on a regular basis, and try to learn from them. Make a peer group in your city wherever you are, and try to make sure that your patient does not suffer the consequences of your oversight. I'm not saying that it's a kind of a negligence, but definitely if you increase your knowledge, it's definitely going to help your practice as well as your patients who are trusting on you. And of course, minor sprains, as well as even the tears. The first treatment is always conservative. The age-old RICE principle, and all those. You need to go to basic principles of first aid, which is taught to probably non-medicos. So I think if you don't do that, then it's quite challenging. Second thing is you need to understand the limitation of ultrasound. So ultrasound is very, very, very good in dynamic assessments, but it is highly operator dependent, and even two similarly qualified guys may have slightly different reports, which may be devastating for the patient. Of course, with the newer, the more and more scanning which is happening, these differences are now reducing. But then it's better to have you write your ultrasound, whatever scanning findings you have on the prescription, and then try to get the MRI scan done, and also compare how much information you provided and then how much you get from the MRI, and this can be a good point to start. Don't think about the cost. Just explain to the patient, and once you explain to the patient, especially young ones, these MCL tears are not uncommon in young patients. It's mostly you will see these falls and all that in the younger population. So it's imperative to start this way. I think let's move to the second paper if there's no more discussion of the faculties. Akhil, Sasmit, do you want to ask anything or comment on the first this Dr. Sasmit's paper?
No, sir.
Okay, so over to Dr. Kanchan and Dr. Aanchal. Please go ahead with the second one. I think you want to discuss about anything about the other paper or something.
Akhil, did they mention about how long did they get the pain relief? Like, was there any mention of any follow-up?
So they did follow up till 3 months, and they the only thing they mentioned with the follow up was that the patient had good pain relief and occasional slight pain on the anteromedial aspect, and that they attributed it to the tendinopathy. But other than that, they did not mention any reduction in the VAS score. The VAS score was 5 when the patient came, and they had not mentioned the VAS score on any follow-up. On even on the 3-month follow-up, they have not written the VAS score.
Yeah, I think I also did not find it, so that's why I was just confirming. So I think when they have the only thing I wanted to say is if you are writing a paper, when you are saying that ultrasound is something you can use instead of MRI or in place of MRI, if somewhere if MRI is difficult to get, or because of the cost or because of the number of the patients, then at least they can have done after 6 weeks or 8 weeks ultrasound scan, which they can done and shown that now there is no bursa, or like compared it. I think if that they would have added, it would have added value to the paper just to, and it'll, just add that, how ultrasound is easier for the follow-up, like we always do in our cases when we do the bursa or the cyst or any ultrasound guided evaluation, doing it in the follow-up, like 6 weeks or 8 weeks or 3 months, whenever you're following, doing the repeat scan and, having it published, like you can just follow up with the ultrasound and you can replace it with MRI if that's what they wanted to, convey. This is one thing. And second thing you already highlighted, I think the scan, which they could have done in the transfers, that would have been, more visible. And so the follow-up was the thing. I think the rest of it's a case report. And
I think it was more of, I think it was more of discrepancy, because they mentioned that they are doing a lateral approach, and in the image they have shown a longitudinal scan, and they have shown a line of a needle coming in plane through the tendon,
right. Yeah.
and I think it was maybe a discrepancy, and the patient was a traumatic patient. 1 year back, the patient had a trauma, and in 10 months,
that could be an incidental finding, like, like we always attribute our things like, trauma. Maybe nothing happened at that time and it was just a,
I think even in that bursa, the image the authors gave, the bursal distension was also not that significant. Even to come to a diagnosis, they should have gone for an MRI, because the inflammation or distension of the bursa could be because of anything, any underlying condition which could not be diagnosed on an ultrasound. I think MRI should have been done, but then.
No, I do not agree with that, because with ultrasound, at least anterior knee, you can find out everything very well, except that ACL. And even now the newer techniques they have come where you can find out even the ACL also, right? Nicely, you can see the two bands of it. What I really was very much surprised to see, when you look at the image, if they would have put 2 or 3 images, it would have been very easy to find it out that there was a track, from the deep bursa, there was something which was going through the patellar tendon. The patellar tendon, one whole. Can you please show that picture once again? Because this injury, I was, yes. See, can you see it here where it is getting inserted on the tibial tuberosity?
Okay, this.
Yeah, this one. Come little more, yes. Okay. So it is like something which is going like this, but I don't know. They have not, like the scan, somehow I'm not very happy, because they should have taken this patellar tendon. We should not stop it the moment we see the tibia coming up. We should follow it till the tibial tuberosity. And the second thing is, if you just show me the picture of that lady, they have shown the picture as well now. See, this side, it is very important that you should evaluate your iliotibial band as well, right? Because she says that she has got pain at the extremes of knee flexion and extension. So your iliotibial band will move, okay? So at this position, somewhere here will be a Gerdy's tubercle. So they should have at least evaluated the lateral side fully. They have not mentioned anything about the Gerdy's tubercle also. And what they have done about this patellar tendinopathy, right? Because that needs to be corrected. And I do not see it as a tendinopathy. I could see it as a tear of that, because you see, it is like, tendinopathy, when we say, what exactly are we looking for? So tendinopathy is basically a spectrum. You have tenosynovitis, you have tendinosis, you have partial tear, you have complete tear. Just like that, you cannot say, okay, patellar tendinopathy is there. You need to specify, because you are looking at the tendon. So when you say tendinosis, yes, they have mentioned about it, but they have not done anything about it, right? So if it's a tendinosis stage, means already it has become chronic, and it is like, after a year. So tenosynovitis will happen in the initial time when you can just think of all the conservative treatment. But once it becomes tendon injury, becomes chronic, then you need to intervene. You need to do something for the tendon also. But I feel it is not more of a tendinosis, it's a partial tear, because one whole layer of the patellar fibers, they are not visible to me very nicely. So I think the picture, it's not very much nice. Not the short axis you just show me. See, it's all gone here. I'm not able to see. So it is not a very good image to comment, I should say. I am not at all happy with the images which they have taken, because they should have at least taken it till their insertion. Now here they are something, they have not even seen they have not even taken the pictures of the retinacular fibers also, right? Because you have the patella, then you need to evaluate the patella, you need to evaluate the retinacular, right? Both sides. Maybe this patient would be having some injury to the retinaculum also, right? So that could have been also displacing to the patellar instability. So all these things you can very well find it out with ultrasound, but there is no mention of anything. So I am not at all happy with the pictures what they have put.
They have even repeatedly said that they have measured the distance, the patellar tendon distance as well as the bursal distension, and they have not mentioned any values of the measurements that they have taken.
I think and that too, deep infrapatellar bursts are very well you can see with ultrasound.
Yes.
Even the physiological, you see some amount of fluid. So imagine if it would have been enlarged very nicely, you can see. See, now that's what I'm telling you. You see the tendon, the whole area is, the layer of the fibers is missing from there. It doesn't happen in tendinosis. Tendinosis, you have an increase in the size of the tendon. You have the tendon's fibrillar architecture will be lost. It will be appearing hypoechoic to you, but you will be able to see the fibers. I'm not able to see the fibers in that particular area. So I do not think it to be a tendinosis. I think it's a partial tear of the patellar tendon, and might be it's a complete one that you have a connection from the deep patellar which is going towards the skin. The tract itself, because the scanning, you have to see the dynamic scanning in order to see the tract. That is not being done here. So that is also there. And drug, obviously, you have said. So that's all from my side. I think that's all I can add on.
I think Dr. Sidharth is having some
Okay.
issues.
No,
the
I'm
internet.
here, guys.
Okay.
So I think we are done with both the dissection of both the papers. So as I mentioned, this is just a critical analysis. We are not taking nothing away from the authors, but definitely this gives us a lot more insight into how we should conduct our practice and what possible lacunae can be filled. Of course, as Dr. Aanchal and Dr. Kanchan mentioned, I can do everything from the front of the knee. So that it's highly dependent on the training of the user or the doctor who is conducting the scans. And in case you are not confident of doing it, so there is no harm of you get an opinion from somebody who can. So maybe if you are around Jaipur, you can take Dr. Kanchan's help.
You can order an MRI if you are.
Yes, or you can, increase your knowledge, and probably that will be great. I think Dr. Kanchan, I have seen her grow, so she is still learning. Every day I see new certifications to her name. So similarly, we should also increase our knowledge, because this is a field where it's a kind of a blue ocean, wherein you all can widen as much as possible. So, and then we discuss all this and learn from each other. I'm sure next time I'm going to even be more, yesterday only I had one friend of mine who had suffered a fall, and I saw everything, and I told him, for your MCL, ACL will do this thing, an MRI, and he did it, and there was a complete tear of ACL. So, bad luck for me and my friend, but then definitely I told him that there was some amount of fluid around your MCL, and I could tell him that there was, and luckily the scan, the MRI also showed that, and I was kind of vindicated. So you feel good when your diagnosis is reflected on the MRI. So try to buy that lottery ticket and try to deserve that win once you get the MRI done. And of course, the advantage which I could get was I just put him on a good anti-inflammatory medication, and next day it was 80% pain relief, and irrespective, we got a young chap, so we got a good arthroscopist opinion done, and because we want to give him the maximum chance at recovery. So that's a topic for another time. Maybe we can discuss more about that. So before we finish, closing comments from any one of you, please feel free to.
I would like to say one thing, that yes, ultrasound you can do everything. Yes, it has got certain limitations also, but always in a country like India, order an MRI to be medico-legally safe. Okay, whatever diagnosis you have made, like Dr. Sidharth was talking about the ACL. Yes, you can find out, but still, to be on the safer side, to keep your skin clean, order an MRI. You can just tell that I am able to see these findings in the ultrasound, but I would suggest you that you go for an MRI, and it will be good that we will be able to correlate it very nicely, and we will be able to provide you the best treatment, because ultimately what matters, ultimately it's the patient who is more important for us. Whatever knowledge
Yes, the
we
most
have,
important is the
yeah,
patient to us. Yes.
that is the thing which we should be doing. And yes, keep on learning, because there is no end of it. Still, what Dr. Siddharth was telling, I still feel I'm learning a lot, because ultrasound is such a raw area, and it will really be helping you in making out your day-to-day diagnosis very easy. Some of the things will be there as image findings also. So do not try to treat the image, right? Try to correlate the image with the patient symptoms. Some of the patients, they will come with some, like example, a tear in the supraspinatus, but everything will be perfectly fine. Then you are not supposed to treat that tear. It is just an incidental finding which you have made out with ultrasound. Don't try to treat the incidental findings which you are just getting it with ultrasound. That is the most important thing which you should be doing in your day-to-day practice. Treat your patient's pain generator. Don't treat the images. Okay? And I hope it's everybody is learning, and we are also learning from each other. And this will continue.
Great. So with these words, I think now come to the end. We don't have any further questions on the social media as well. So maybe these questions come in the retrospect, because most of these guys, they probably see it after it has been pushed in. I think I'll just end this session for today, and we're going to just go on to my my presentation. Just a moment, guys. Got so many presentations open. Okay. So I hope you all can see my screen. I think today's discussion was very fruitful. So thank you. Thank you, Dr. Sasmit. Thank you, Dr. Akhil. Thank you, Dr. Aanchal Sharma. Thank you, Dr. Kanchan Sharma, both of you. I think this was one of the nicest discussion in the recent times. So thank you all of you, and I hope that next time we even dissect the papers even more. So let's go on to end the session for today. This is the season 4, where we are focusing on MSK ultrasound. We have a new time. This time we are meeting at 8 p.m. We have a group topic for seasons. We have 2 faculties, 2 papers in this season. We have got papers which are pushed in advance. At least I try to push it a day in advance now. Join our mailing list. Those of you who are not there, I've already posted the WhatsApp group link in the chat and email. Suggestion, comments are welcome. I personally review this email, so you can just mail me on mumbaiPainSchool@gmail.com. And next Friday, we are meeting with a new topic. So stay tuned, and see you guys next Friday. And those of you who are wanting to attend the live workshop, we have the next one, 26th to 28th April in Mumbai. So I'll be putting up the links very soon. We have almost finalized the program, so looking forward to seeing you all there as well. So with these words, thank you very much, and I'll just end the meeting for today.